Epilepsy, also called a seizure disorder, appears in many different forms. Approximately 300,000 people in Canada have epilepsy. At one time or another, most educators will have a child with epilepsy in their classroom. Epilepsy is a neurological condition that causes a person to have recurring seizures. A seizure is a brief disruptive discharge of electrical impulses in the brain. It may involve the whole brain or just part of it. The brain acts like a computer, directing the body by sending tiny electrical signals between neurons or brain cells. They switch on and off millions of times a day, but sometimes the neurons fire inappropriately, and that could cause a seizure.
So epilepsy is really a simple definition. It's having one or more unprovoked seizures and a tendency to have more. The cause of epilepsy is different for many individuals, and so epilepsy in itself is a very heterogeneous condition, and it really depends on the individual.
When somebody asks me what epilepsy is, I say that it's not a disease. It's just something that you need to live with, and something that happens to your body either in the day or at night, where your body kind of shakes uncontrollably at times, or it can just happen. You could phase out.
There are two classifications of seizures, generalized and partial. Generalized seizures happen when the electrical disturbance occurs in the whole brain. Partial seizures happen when the electrical disturbance occurs in just one part of the brain. For example, simple partial seizures can cause changes in sensation, vision and sound, movement, or even feeling, depending upon what part of the brain is affected. The most common types of seizures in children are absence, simple or complex partial, tonic-clonic.
So an absence seizure, or what they used to call it was petit mal seizure, are characterized by sudden onset and sudden offset of really a lapse of awareness or decreased responsiveness. So it comes on quite quickly. They may see children having some eyelid fluttering, eye rolling. Sometimes some lip chewing can be seen. They're usually quite brief, less than 30 seconds, and the offset is usually quite quick like that. They usually come right back to consciousness, and they may be aware of actually missing out on time, and they do not remember the events that happened during it most of the time. These can happen 100 times per day.
This girl has absence seizures. You'll see her have one while she's talking. She stops talking in the middle of a sentence, and there's a vacant look in her eyes. Sometimes absence seizures are so short they're easy to miss. This boy is having frequent but very brief episodes. You can see his eyes roll up and his eyelids flutter.
Well, when I have a seizure, I can't really feel anything. I don't know when it's gonna happen or anything. My seizure looks like I am having a blankout or I'm daydreaming. Just stay normal and just be aware that I'm having a seizure. So when I come out of it, tell me where I am and what I was doing a second ago.
She'd all of a sudden go into this staring spell in the middle of a sentence and just be drifting off into space and kind of staring behind us or just staring off. And then all of a sudden, after maybe 10, 15, 20 seconds, it depends on how long that particular seizure was, she'd immediately come out of it. And then you knew she was kind of a little bit rattled because she'd just shake her head a little bit and say, "Oh, what was I saying?"
So partial seizures can look like, so very many different things depending on what area of the brain they come from. They can be very subtle or they can be very obvious. Something is called a simple partial seizure if they seem to be completely aware throughout the whole event and they remember it. And something is called a complex partial seizure if it seems like their awareness is decreased. Depending on where in the brain they come from, they can look different. Common things that one may see with partial seizures is staring, unresponsiveness, sometimes some chewing motions, swallowing motions, salivation, sometimes some picking motions with the hand. Sometimes simple partial seizures can be jerking of a limb or one side of the body. Sometimes they can look like, sometimes you don't see anything, and the child will describe sensations or abnormal sensations that you can't see. Sometimes they can be feelings inside of them, such as fear or a feeling of déjà vu. So they really do differ. The length of time is usually anywhere from a few seconds to a few minutes.
This young man is having a complex partial seizure, and his consciousness is impaired. These seizures are the most common form of epilepsy in teenagers and adults.
Kevin? Kevin?
Complex partial seizures may create a variety of automatic movements or behaviors, such as this young woman is having. She cannot control these movements, nor is she aware of them. The movements of her hands are automatic. They look like deliberate movements, but they are not. They are part of the seizure. Her awareness of her surroundings is clouded.
For the most part, my seizures pretty well aren't visible to people around me unless they're speaking to me, because my seizures come from my temporal lobe, which affects speech and memory. So essentially when I'm having a seizure, which is anywhere from about 10 seconds long to 60 seconds long, I can't really understand what people are saying to me at the time, and I can't express myself either. And I usually have sort of a feeling of jamais vu, which means that I feel like I'm remembering something, but it didn't actually happen. So it's quite disorienting.
Complex partial seizures only last a minute or two, though the person may feel confused for a while afterwards. These could be misinterpreted as behavior problems. If restrained abruptly, the person may strike back in a reflex action.
So the generalized tonic-clonic seizure, or what used to be called the grand mal seizure, are the seizures which the whole body is involved. And, the children are usually unconscious. It usually starts with a stiffening of the body, straight like a board, and then afterwards clonic jerking of the extremities, so rhythmic jerking of the arms and the leg. The eyes may roll up. There may be some decrease in breathing, and they may turn a little bit blue around the lips. There may be some foaming at the mouth. These ones as well are usually brief, usually less than a few minutes.
Mr. Ehrenberger, my science teacher, was explaining something, and right down to the very last second, I remember everything, and then I just blacked out, which I thought I did.
Understanding first aid for seizures is probably the #1 thing that people can do for themselves to better dispel some of the fears and misunderstandings about epilepsy, and understanding what you can do to help out gives people a sense of control, and that helps give people a bit more confidence. So the primary steps for first aid for seizures, for a convulsive seizure to start off with, are first and foremost get the person into a comfortable and safe position. Usually that is lying on their side. It doesn't matter which side. You want to move anything out of the way that they may bang up against, or that they may hurt themselves if they were to hit. If you can cushion the head if it's a hard surface, that would be more comfortable. And you want to loosen anything that's tight that might constrict the airway around the neck. Beyond that, you want to keep the person comfortable, try to stay as calm as you can, reassure them, never under any circumstances put anything in their mouth. Don't try to restrain them during a seizure.
Usually, it's not necessary to call an ambulance for a tonic-clonic seizure, but there are exceptions. An ambulance should be called if a seizure lasts more than 5 minutes, or if you're unsure of how long it has lasted. For first-time seizures, repeated seizures, or changes in seizures, or if the person is injured, has diabetes, or is pregnant.
For patients who are not having a convulsive seizure, they may stare, they may appear confused, they may say unusual things. you don't need to lie them down. You need to keep them in a safe place and not restrain them. So if they're standing at the top of the stairs, you want to move them away from those stairs and allow them to move freely in a safe environment. You want to stay as calm as you possibly can, and you want to reassure that person. And again, when the seizure is over, it's very important to reassure the patient, as they may have no memory of what has happened.
Recognizing seizures and providing first aid are ways to manage epilepsy in school, but it's just as important to help with learning or psychosocial effects. Students with epilepsy may struggle with more than the usual challenges of school. This may include learning difficulties or social or emotional needs. Many children do well once seizures are under control, but epilepsy may still influence school performance in subtle ways. Seizures can affect memory, attention, or certain processing skills.
The most common types of learning problems that children with epilepsy have are attention and memory. However, depending on where in the brain the seizures are coming from, there can be other problems. For example, children who have seizures coming from the left hemisphere of the brain tend to have problems with language processing, language expression, or language-based learning. Whereas children who have seizures coming from the right hemisphere of the brain might have problems with visual spatial processing or visual learning. And children who have seizures coming from the frontal lobe of the brain might have problems with attention, focusing, behavior regulation, emotional control, and things that we call executive functions, which include organization and planning, initiation, monitoring, those kinds of functions, shifting. So depending on where in the brain the seizures are coming from can lead to a different learning profile. Many children who have epilepsy have had problems in the development of their brain and have abnormal electrical activity in their brain, and as a result they can be less efficient in their learning, and they can have higher risk of learning disability or behavior problems. Children who develop seizures early in life, such as in infancy, tend to have a higher risk of having learning and behavior problems, and may even have intellectual disability. Children who develop seizures later in life, such as in school-age children, have had several years of typical development and tend to do better and may have learning disabilities or no problems at all. The other factor that can affect learning and behavior in epilepsy is the medications. Many of the medications that children take to control seizures have side effects, cognitive side effects, behavioral side effects. Now, some of these medications are better than others in terms of side effects, but it's not uncommon for children to experience changes in their ability to pay attention and focus when they're taking medications. They may experience fatigue, they might have slower processing, and some medications are associated with agitation or anxiety in children. Ideally, if a child with epilepsy is having learning problems in the classroom or behavior problems in the classroom, the best case scenario would be for them to have a neuropsychological assessment, a comprehensive assessment to understand the source of the problems, why they're having the problems. And with that information, we can develop interventions to best support the child in the classroom. However, neuropsychological assessments is not always an option for children with epilepsy. And in those circumstances, there are several strategies that can be easily implemented in the classroom that can support them. I find that the most common recommendations that I give for children with epilepsy include things like breaking down the assignments. Children with epilepsy tend to become easily overwhelmed when too much is thrown at them at once, and they don't know how to manage a lot of information at once. Therefore, breaking assignments down for them, breaking the lessons down for them, and presenting it in small chunks at a slower pace tends to be quite effective in helping children learn to their potential. In addition, repetition is a very important way to support children who are having trouble with learning. So repetition, whether it be in the format of a learning assistance block, being able to go over lessons, or even after school with a tutor, but repetition, repetition, repetition tends to be very helpful. Children with epilepsy tend to do very well with structure. So both the structure of the classroom, a highly structured classroom and learning environment, but also structured presentations of new information, being very aware of presenting things in a logical, meaningful way, so that when it's learned and encoded, it's learned in a way that has an inherent structure to it. Contextual learning can be very helpful for anyone who has learning problems. Making the information meaningful, linking it to something that interests the child or that the child already knows, can be very helpful in helping them remember information later on. And then finally, extended time. Many children with epilepsy have processing speed problems and need extra time to finish their assignments or their tests, including provincial exams, in order to demonstrate their knowledge and what they've learned, or to perform to their potential.
Most children actually are pretty okay with having epilepsy, and life can go on like normal. It's only a small group of children, a small percentage that suffer from very severe condition that they need to be extremely careful. And for the teacher to know of the wide range of reactions, it will actually help the teacher. For the teacher to talk to the parents or the healthcare professional to know what to expect from the child, whether it's from the symptoms, the reaction, and from their own response. If there would be a seizure in the classroom, they would be that much more prepared. And at the same time, they would be able to tailor-make the social, emotional, and academic expectation for the child.
I think one of the most important things that we can all remember about a student with epilepsy is that this is a normal child. They just happen to have the tag epilepsy added to their name. This child is normal. At the high school level, they're going to be an adolescent when everybody else is an adolescent. They're going to go through the same problems that every other child is. Sometimes they want to eat, sometimes they don't want to eat. This is not abnormal. The one thing that we do have to be aware of with a child with epilepsy is to watch for the seizures and learn about the triggers and learn how to handle them. And once you've been through one seizure, you feel like a pro because, oh, that's what's happening. And the kids are so blasé about it too. Just, they see this happening. Oh, so-and-so's having a seizure, and they all have a role. I'll get this, I'll get that. It's fine. They wake them out of it, walk them out of it. The best way for a teacher to learn about a student's needs is through the parents themselves. The parents know that child, number one, more than anybody else. They know the ins, the outs, the ups and downs, what does work, what doesn't work. They may not have the educational background, but they know how this child works. And if you can get the parents on board and get the parents to explain about their child, you've got a really good basis for going from there. With lots of patience, a child can be integrated into anything. I feel that if you have an educational worker or a resource teacher really on board with what this child's difficulty is, you can find a way to get them into the regular day program, into what's happening in a science classroom. Again, there are so many different levels of epilepsy that affect a child, from minimally to children you never know have this, to children who are going to be a major focal point in some classes. But to integrate them, yes, you need these adults who have the training, the medical training. They have to have the strategy training, and you work as a team. You can't just expect one person to go in there and do the job. You work as a team to create what is best for this child.
I think it's very important that teachers are aware of what's going on as far as children that have been diagnosed with epilepsy and the possibility of seizures and what they look like, because to have that awareness as a teacher really helps. And I think as a teacher, I was a teacher of 20 years, and then watching my daughter go through these these seizures and not having any understanding or awareness of what that was. I just wonder how many kids I've taught in the past 20 years who've actually had seizures and I didn't know.
For thousands of young people, epilepsy is a part of their school experience. Some will need lots of help, others not so much. But all students with epilepsy have a right to an environment where people understand their needs and where people accept and include them in all aspects of school life.